بسم الله الرحمن الرحيم. This video is continuation of the previous videos about pulmonary hypertension. The portal hypertension, which is one type which is present in the category of clinical group 1 of pulmonary hypertension. Here, pulmonary arterial hypertension is seen in up to 5% of patients with portal hypertension, whatever the cause, increasing with duration of the liver disease. Portopulmonary hypertension is probably due to the failure of the liver to remove vasoactive substances from the portal circulation, with their resultant accumulation and presentation to the pulmonary arterial endothelium. Congenital heart disease. Pressure overload caused by systemic to pulmonary shunts, including large defects such as in Eisenmenger syndrome, moderate to large defects, small defects such as in small ventricular and atrial septal defects, and smaller defects may not explain the degree of pulmonary hypertension and behave more like idiopathic pulmonary arterial hypertension. Here, clothing the defect may not help. Schistosomiasis, portal hypertension along with local vasculature or local vascular inflammation caused by schistosoma eggs. It is a common cause worldwide. Chronic hemolytic anemia and pulmonary arterial hypertension includes sickle cell anemia, thalassemia, hereditary spherocytosis, stomatocytosis, microangiopathic hemolytic anemia, and may result in pulmonary arterial hypertension. The mechanism is related to a high rate of nitric oxide consumption, leading to a state of resistance to nitric oxide bioactivity. Pulmonary arterial hypertension long-term responders to calcium channel blockers. A minority of patients with pulmonary arterial hypertension will show long-term response to calcium channel blockers. Last type in clinical group 1 is pulmonary veno-occlusive disease and or pulmonary capillary hemangiomatosis. There are difficult disorders to classify, share some characteristics with idiopathic pulmonary arterial hypertension, but also a number of differences. High resolution CT is helpful in diagnosis. Characteristic interstitial edema with diffuse central ground glass opacification and thickening of interlobular septa. Possible lymphadenopathy and pleural effusion also occur. Pulmonary capillary hemangiomatosis suggested by diffuse bilateral thickening of the interlobular septa and the presence of small centrilobular poorly circumscribed nodular opacities, while biopsy can help confirm the diagnosis, and it is not currently recommended as it is high risk. It can be idiopathic, inherited. Consider genetic testing for ELF2AK4, drug and toxin related, industrial organic solvents, particularly trichloroethylene, associated with connective tissue disease or associated with HIV. Now the group 2, or now the clinical groups from 2 to 5. The clinical group 2, which is pulmonary hypertension due to left heart disease. This includes heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, valvular heart disease, and some congenital heart disease. The clinical group 3, pulmonary hypertension due to lung disease and or hypoxia. The majority of patients with pulmonary hypertension seen by a respiratory specialist will have pulmonary hypertension due to chronic hypoxic lung disease such as COPD. Chronic hypoxia causes pulmonary vasoconstriction and, in the longer term, vascular remodeling, inflammation, mechanical stress of the hyperinflated lungs, loss of capillaries, and toxic effects of cigarette smoke all contribute to the pathological mechanisms. Patients without proportion of pulmonary hypertension due to underlying lung disease should be referred to a specialist center that is dyspnea insufficiently explained by mechanical disturbances, mean pulmonary arterial pressure more than or equal to 40 to 45 millimeter mercury at rest. COPD, chronic obstructive pulmonary disease. Pulmonary hypertension is often an incidental finding in a patient with a chronic respiratory disease. A significant proportion of COPD patients will develop pulmonary hypertension, possibly up to 25%. The level of PAP in these patients is much lower than that seen in patients with pulmonary arterial hypertension. COPD with pulmonary hypertension has a much poorer program than COPD without pulmonary hypertension. In patients with pulmonary arterial pressure below 25 millimeter mercury, the 5-year survival is more than 90%. In those with pulmonary arterial pressure more than 45 millimeter mercury, the 5-year survival is below 10%. Whether this is due to pulmonary hypertension itself or whether the pulmonary hypertension is a marker of a worse hypoxia and disease severity, and the disease severity is unclear. Pulmonary hypertension is COPD was thought to be due to hypoxia and emphysematous destruction of the vascular bed, but neither of these factors correlates well with pressure, pulmonary artery pressure. Cigarette smoke may have a direct effect on the intrapulmonary vessels, with the upregulation of mediators leading to apparent vascular structure remodeling and physiological changes in vascular function. Other causes of pulmonary hypertension due to lung disease include interstitial lung disease, other pulmonary diseases with mixed restrictive and obstructive pattern, sleep disorder breathing with obesity, hypoventilation syndrome, not just obstructive sleep apnea, alveolar hypoventilation disorder, such as due to neuromuscular disease. Both alveolar hypoxia and hypercapnia produce pulmonary vasoconstriction, thereby increasing pulmonary artery pressure. Chronic exposure to high altitudes, developmental abnormalities. The group 4, clinical group 4, chronic thromboembolic pulmonary hypertension and other pulmonary artery obstructions. The CTEPH, chronic thromboembolic pulmonary hypertension, a frequent cause of pulmonary hypertension with both proximal and distal clot. Recent data suggests that chronic thromboembolic pulmonary hypertension occurs in up to 4% of cases of acute non-fatal pulmonary embolism, higher than previously thought. Pathogenesis is unclear, but abnormalities in the clotting indicate endothelial cells or platelets may all contribute. Natural history of pulmonary thromboemboli is resolution or near total resolution of clot with restoration of normal pulmonary hemodynamics within 30 days in 90% of patients. Right sided pressures return to normal in most patients by 2 weeks. In chronic thromboembolic pulmonary hypertension, the thromboemboli do not resolve, forming endothelial, endothelialized fibrotic obstructions of pulmonary vascular bed. In situ thrombosis and vascular remodeling of small distal pulmonary arteries also contribute. Peripheral pulmonary arterial hypertension, like arteriopathic changes, are also seen in the distal pulmonary arteries in non-obstructed area. Collateral vessels from bronchi, intercostal, diaphragmatic, and coronary arteries can develop to partially reperfuse areas distal to complete obstruction. The clinical deterioration parallels the loss of right ventricle function capacity. Risk factors for chronic thromboembolic pulmonary hypertension include increasing age, idiopathic pulmonary embolism, and a larger perfusion defect. A splenectomy is possibly by inducing a prothrombotic state due to loss of filtering function of the spleen. Antiphospholipid antibodies are present in 10 to 12% of patients. The diagnosis is usually made until advanced pulmonary hypertension is present. Progressive pulmonary hypertension seems to result from changes in the small peripheral resistance vessels in the vascular bed, as opposed to being due to progressive pulmonary events. Secondary hypertensive changes, probably induced by high pulmonary artery pressures, lead to incremental increase in the right ventricle after load, with increasing pulmonary hypertension ultimately leading to right ventricle failure. Patients with chronic thromboembolic hypertension have a 5-year survival of below 10% if the pulmonary artery pressure more than 50 millimeter mercury. The, the CTPA helps determine whether there is any surgically accessible chronic thromboembolic pulmonary hypertension. The treatment options include central or distal pulmonary end arterectomy, catheter-related balloon pulmonary angioplasty or inoperable disease, or following pulmonary end arterectomy. The clinical group 5 pulmonary hypertension with unclear and multifactorial mechanisms, heterogeneous conditions with different pathological pictures, etiology, unclear or multifactorial, include hematological disorders such as myeloproliferative disorders, splenectomy, systemic disorders, sarcoidosis, pulmonary Langerhans cell histiocytosis, neurofibromatosis vasculitis, lymphangioliomyomatosis. The metabolic disorders include glycogen storage disease, Gaucher disease, thyroid disorders. Other includes tumoral obstruction, fibrosing mediastinitis, chronic renal failure on dialysis.